Well, let me just start with a comment. I mean, I think the data on non-invasive ventilation and acute lung injury is pretty, it's really impressive. I know I've seen it and I know a little bit about it, but if you think about Bob's talk this morning about non-invasive ventilation, key critical issues related to non-invasive ventilation are the interface, and it's a difficult issue. And if you don't have the interface right, you get leaks. And if you have leaks and you may want to increase pressures, you may end up with gastric distension. And as we saw with your data, if this works out in humans in the same way, essentially you don't have any of those problems. So it's really quite dramatic, and we'll see whether that pans out in appropriate clinical trials, but certainly theoretically it looks like it could be very, very exciting. And I think the key here with the gastric distension is something you hinted at or said, that because of the synchronization, right, you can get the pressures of 40 and you don't get gastric distension because the subject or the patient is working their airways in a way that closes the glottis appropriately. You get air where you want it to go rather than where you don't want it to go. So this is open for questions, comments. Here we go.
Could you elaborate on what it exactly is, the tonic electrical activity? What's actually happening with the diaphragm? I'm not quite sure I get it.
Okay. We believe that the tonic activity of the diaphragm is responsible for maintaining like a diaphragm tone. It's keeping the lung open at the end of expiration. It's not allowing the lungs to go back down and to de-recruit. Okay, so if you breathe in and then you breathe out, but you don't breathe out all the way, you keep a little bit of the lung open when you do that. So that's why when you give PEEP, you're helping to keep the lung open by the ventilator, and then the rabbit doesn't have to, or the baby doesn't have to do that anymore.
I think we have shown this by both, if we vagotomize the animals, you would find that this kind of preventative thing during the exhalation period disappears. And moreover, we've been in CT scan studies too in Uppsala, Sweden, together with Göran Hedenstierna, and Lucas Brander was doing that study for us. And in that study too, we have seen that when the lung is recruited from a collapse in an open chest model, we see this tonic activities disappearing. So if you would kind of open up the lung for a rabbit, they will take away this tonic activity. And this is like, I think it's like something which Jennifer was showing in her graph, but maybe didn't mention, that it seems to be that when we start and see a healthy subject breathe, you see like a slow increase of the diaphragm activity, and then it sets down, and then there is nothing, and then comes another slow increase. When you start to become compromised, that you can't keep the lungs open, it seems that you reverse this pattern. You seem to want to recruit, but not let down. So you kind of reverse this. You go up fast and you go down slow. At its extreme, when you let the lung collapse in an open, if you make a neuromotor, just let the lung collapse, you just see this tonic activity goes way up there, and it just stays there until you have reinflated the lung. You can see the diaphragm just disappear straight in the chest, just like that. And this is just a primitive reflex that is just saying the lung should not collapse on us. It gets blunted with age, so I mean it disappears. It's again wrong. It doesn't disappear. Both Condili and Maglionis have shown very elegant papers that this reflex is really active. And as I showed in my data, in our data here on pressure support, is that when you increase pressure support, you do reduce the respiratory rate, and that is shown by Condili that this is only due to that you're increasing the pressure assist into exhalation, neural exhalation period, which prolongs the expiratory time. So it's a very important new thing. It's been alluded to in the past several times, but nobody never came up with conclusive data in science. Now we can measure it every day. It's like available.
Question up here?
Yeah. You very briefly touched the very interesting area or issue of hemodynamics, and actually about heart-lung interaction is probably something of an area which will be very, very interesting indeed in terms of this methodology that you're talking about now. The way that really, I mean, talking about, say, left ventricular or afterload, say, ventricular wall shifts, or venous return. Would you like to comment on that, or the data that you might already have?
I don't know very much about the hemodynamics. It was this fellow that was visiting
We got to
us,
ask Lucas then later.
We can talk about it later, or unless you want to.
Yeah, I think we have, I mean, when Lucas worked with us, we started to do a series of preliminary studies, which are very, very promising. And in these studies, it shows that there is a nice interaction between, it's not only breathing. I mean, when you inflate the lungs, I mean, what gets squished in the middle is the heart. I mean, that's where there is no space for anymore. I mean, that's the problem. PEEP up to a certain level is good. Above a certain level, it's really not good. And I think Lucas, in this case, his plan is to continue this work with Jukka Takala in Bern, and I think they will follow up on this. They have all the setup. They have an amazing lab. They work in there. Yeah.
Very briefly, I mean, if you take the list of contraindications presently for non-invasive ventilation being hemodynamic instability, I think that might change in the future with a methodology like this.
Yeah. And I think your point is a very good one about the hemodynamics. I think it's important to bear in mind it's a little complicated to study hemodynamics and ventilation in the sense that APRV is a good example. A number of studies show that cardiac output increases. Well, the issue is you've got supply and demand, and if you've got a technique that increases the work of breathing, increases the oxygen cost of breathing, your cardiac output might go up, but that's not necessarily beneficial for the patient. So you have to look at the demand side, you have to look at the filling pressures, but I think you're right with the negative pressure, this might be advantageous in terms of hemodynamics. Yes?
At risk of sounding simplistic, how do you wean on NAVA? That I haven't heard, and I think that's going to be a very key question from our when we take this message home. And because yes, we can do all these things, but how do we know when we've been there?
That's not simplistic at all. That's a great question.
Yeah. To start with, I think one can say that NAVA is, in a sense, a self-weanable mode. It sounds a bit funny, and again, I'm almost apologizing because everything sounds so good, but it's like, it actually is like, I mean, we work with this for many years, and of course there are things that you will have to deal with. You have to change your practice. That's I think that's the biggest problem. But from the weaning perspective is to say that, I mean, as I showed in these titration runs, if I increase the assist to a certain level, so I turn this knob and I say for a given diaphragm activity, you're going to get more and more and more pressure. Now, if you have that level and you say that you become worse, your activity goes up, that means your pressure goes up. Well, in that case, you are working more, but you also get assisted more. So I keep you more in the same level. Now, if you get better, your assist goes down. And in this case, if you see a continuous trend of assist going down, the drive is going down, everything, I mean, this indicates that you are, for some reason, either getting more sedated or you are actually becoming better, your drive is reduced. And I think from this perspective is that number one is you can see the trend of neural activity over time, which is a weaning index in itself. I mean, if you take me now, and I would have a car crash and God forbid, but I mean, come in with an ARDS, you would see activity up to here. After 3 days on the ventilator, you see the activities down here. You would say, why is he on the ventilator? He's completely not in need of that. And we've seen that in a lot of patients, and even people who worked in Sweden I know had that observation too. It's like, well, the assist is not, pressure doesn't go up very high, there's not very much activity. Why don't we try to wean this patient? And we've done it in Montreal, we've done it in Toronto, they've done it in Sweden, and patients come off. I think there is like, the reintubation ratio is something like 10% or something like that, very small. But the other thing is also that the mode in itself is an auto-wean mode, because if you get better, the drive goes down, that means the assist goes down. So you are actually removing the assist to yourself.
Let me also make a prediction. I don't know if this will be the case. You know, there have been a number of studies looking at post-extubation use of non-invasive ventilation. And in general, I would say that the data are not good that that's helpful. But I think with NAVA potentially, you know, you could extubate a patient you think is ready. And let's say they do need some extra assist. You've got the catheter down. You could use non-invasive ventilation because it would be so easy and you don't worry about the leaks. That I think that we'll be extubating patients earlier potentially using non-invasive NAVA after the extubation for a period of time. And I think that may be how this ends up being used in the future. As I've said multiple times, I think it's important, though, we need clinical data, we need some clinical trials to address this.
Earlier we were discussing that fact that I think NAVA is going to be much more important, or it's as important in the invasive ventilation as the non-invasive, and I think that's very true.
Can I ask you a question too? Can I ask a question? How do you both hinted at this, but I don't think you addressed it directly. How would you set gain on NAVA in patients?
Again, it's your...
It's mine? Okay. Well, I would say, how do you set gain in any mode of ventilation today? That's my... I mean, you might believe in 6 ml per kilogram, and since you're my boss, I do as you tell me, but, you know.
Okay, next question.
But I'm not sure we know, and I mean, I think for what Jennifer showed and in all these examples, I mean, how sure are you today when you go back and see your waveforms that this guy is actually neurally breathing or not? Are you sure about that now, or do you have that kind of feeling that I don't really know?
I think
and this is
by the way, just to interrupt for 1 second, is we're probably doing it wrong, but at least we have an algorithm that everybody uses. You know what I mean?
Yeah.
So this will be new.
Yeah.
Let's say someone gets a device. Where do they start?
I think that the first part where you would start is that you would probably have a feel for the patient. He would not come in and be NAVA first mode. You would probably have him on another mode. You would connect him. You would watch the diaphragm activity in this mode. Now, you don't see any activity, for example, as one of these slides, or you see a lot of activity. This would immediately tell you that, oops, this guy needs more assist, this guy needs less assist. You would see how much pressure you deliver, so I mean, you would have a feel for that. The immediate thing for the eye is that when you get used to your patient population and the size of the waveforms, you kind of get the feel for it. You can say, this is a lot of activity, this is little activity. So by eye, you can more or less try to just get them into an eyeballing level. That's, I would say, the easiest way. The more refined way that we try to develop, and which probably is not all perfected yet, but it's getting there very nicely, that is to get a true physiological titration where you actually just increase this assist level. And at some point, the patient will tell you, I don't want any more. But if you have, for example, a patient who is in real bad distress, he will just go on, and you see now pressures are getting ridiculous. He is getting unloaded, but he still doesn't stop his drive. This guy, you would say, oops, here we have some other problems. This guy has a drive of infinity. So you can actually do differential diagnoses here too. So that is the method I believe in the future. You will see normally in your average patient, like a COPD, who is not too sick, pneumonia, whatever you want, that they come to a plateau, and then it's kind of like you turn the knob and you turn the knob, but nothing much really happens. Breathing frequency doesn't change, volume doesn't change, pressure doesn't change. The only thing you see is diaphragm activity is disappearing. And if you turn long enough, you might see some kind of arrhythmic breathing patterns. These are not bad for the patient, but it's like you are over-assisting. So anywhere between the point where you see that you have a plateau till you have what you call complete over-assist, you can just choose and say, if you want to really, really suppress him, you try to keep him with the lowest drive possible. But if you want him to work a bit, like if this is a COPD patient, you want him to go home, and as I show you, they have 6, 7, 8 times our drive. So you don't want to rest this guy too long and too much. So I mean, you might give him 1 night of rest, and after that you have to cranking up there so that he really works hard, and you have to see a lot of signal. And I think that's the way to set it. But it's again, I think for this Congress, I think the thing about new paradigms and paradigm shifts, I think this is really, you have to start to think different. You have to bring neurology into your practice. This is about central control of breathing. This is about diaphragm activity, respiratory drive, hearing Breuer reflexes. There's a lot of new stuff in here, but technically, if you worked with it a few times, I mean, all the fellows who come to us, I mean, it doesn't take long for them to understand how this works. It's really not that complicated when you take it down to its essence. It's quite straightforward.
Any other questions, comments? Microphone down at the front, second row, please.
I wonder if we might think of this as, or ask you if you would use this NAVA in the beginning with a patient who is very acutely ill and whom, as you mentioned, you change the gain and virtually nothing happens. Would it be possible to use the device just to trigger any other breath the ventilator has that the clinician chooses, just as a triggering, just a starting mode, the rest of the synchrony left to, to whatever breath type you've selected, and if it would be worth it to have the catheter down just for that better triggering. And then secondly, in the COPD patient, where this can provide assisting regardless of auto-PEEP, as you talked about, as you presented, it seems to me that you might run into a problem at removal of the ventilator. Again, perhaps non-invasive would be replaced after the endotracheal tube is removed. But at some point, you might get to that point where the person has a natural auto-PEEP is not ever going to go. There's a certain level they're always going to walk away with. And then the weaning from NAVA seems to me to be when you have to allow that person to work against their own air trapping, and they might not be very comfortable when you force that work back on them, and you'd be switching the NAVA on and off and on and off and on and off. Yeah. And that might be a gradual wean type. I'm not sure the other general use that you presented that there necessarily need to be a gradual wean. Anyway, two comments.
I think for answering your second question first is to say COPD patients don't like NAVA. I can say that straight out. They don't like it because they have to work. They have to work, they have to do the work, and they don't like that. They are used to get to trigger the breath and just go for a ride. That's what they like. Don't ask me why, but I have that feeling that it's, and the thing is here, you can unload them to a point that they are comfortable, for sure, but the thing is, should you do that or not? I think this is about winning strategy, because here you are dealing with only one issue, dynamic intrinsic PEEP. That's all you want to overcome. I don't think you won't make their life any better to come to a hospital, to an emergency unit costing $3,000 a day. I mean, you wouldn't think that, yes, I should have a better time here than I should have at home. But I don't think for a COPD patient, a chronic patient should not have that necessarily. Maybe for a limited time, the muscles might be wasted, you might want them to rest a bit. But in the long run, I think that you should allow them to, you should keep them going, because I think, as you say, especially when you get to the very, 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 very sick level, that so you reach close to terminal. I mean, it's a tough one if you take these ones with too much help. You never get rid of them.
Christopher, can I ask you, just as I understand, you said they don't like COPD patients don't like NAVA.
Well, it's an overstatement. If you go up in assist, yes, they like it better, I would say. It's hard to evaluate. We tried in Montreal to use these kind of scales, and we ask patients, and what do they point at? We had a scale that went from 0 to 6, they pointed 3. So we changed, we went from lowest assist to highest assist, 3. We changed between NAVA and pressure support, 3. So it's if I would have said, what's the weather today? 3. I mean, it really turned out like that. We were very disimpressed. We've read a lot of paper on it when we wrote the grant application. We really were expecting that we will get this thing, but in healthy subjects, you get the adequate answer. But in the patients, even if they are, so to speak, non-sedated, they are pretty drowsy in an ICU anyway. I don't know if they are really that interactive. To go to your first question, to just trigger and cycle off with, as Jennifer presented. I mean, you can run pressure support, you can run volume control, you can run anything you want, really. It's the neural trigger and cycling off is two separate issues. NAVA is just like the y-axis, so to speak.
Interesting, when you started saying, be afraid to use sicker patients at first. At St. Michael's Hospital, there's been about 15 patients studied now, and the staff initially wanted, let's try someone really not too sick, inappropriately, right? And just gain confidence. So now much sicker patients now, all in the context of clinical trials, not sort of regular care. But the staff is much more comfortable now with, the sicker patients can be managed. But any new mode like this, you want to get a feel for, and you don't want to stick your really sick patients on until you really understand the mode. And my guess is that's how people will start to use it, and I think that's very appropriate.
I come back to your question actually again there. I think that one thing that we see This might be a little provocative, but it's in all friendliness. This is just an observation we made. It's like when a patient gets a little bit agitated, what first happens is the nurse is there with a needle and gives him a little bolus, so he's happy. And then comes the RT after about 5 minutes or 3 minutes or whatever, and increases the assist or shifts it from pressure support to pressure control or something like that to just keep him happy. The thing is just, when do you guys come back to switch it back again to what he was before? Because he had a little agitation, like you take off the tip, but then he can stay there for maybe, I don't know how many hours. And this is, I think this is the thing that with NAVA you would get more assist. You might need to have some sedation, but you might not necessarily have to do changes of the assist level. And I think the combination of kind of like snowing the patient and then at the same time increase the assist, hyperventilating him. I mean, this is really turning off everything. But this is today's practice. So I mean, this is I guess you do this in most places. I mean, what else can you do? And I think this is where we will learn a lot of new things in that sense, that when we can actually get that the ventilator is actually responding to the increased demand, and you might be that the patient, we had some patients who were, like one patient who was very agitated, but he was going through all his high periods without we had to do anything, and the nurse was never giving him a bolus. He was actually riding through it. So it seems to be this kind of thing, and I think even other modes that are coming, like there are newer modes that try to get to this, and I think we should encourage that to try to be more often at the knob and change it and get modes that adapt to the patient needs, because I mean, you guys cannot just be at every bed at every minute of the day. I mean, this is impossible.
And, go ahead.
I'd like to go back to the patient that kept pointing to 3. At what point did you decide to not ask anymore?
We did, I think, 5 patients, and then we gave up. I think we continued to ask, but we said this is not going to be a part of the publication. It's a part of the protocol.
3 ± 0. I mean, just, great data.
It was a part of the protocol, so we had to stick to the protocol, but we decided that I don't think this is, or we don't believe that this is reliable information. It's
Any other questions, comments? Let's get you a microphone. 2 rows back behind you.
Can you speak a little bit about the possible increase in infection due to the catheter and how that would entail using that in non-invasive mechanical ventilation if this is an invasive catheter that you're placing in?
well,
Maybe I'll address part of that, I think.
Yeah.
Remember, this is a catheter going into the esophagus, not into the lungs. And we often have patients with feeding tubes that are in for a long period of time. It's, but anything invasive, clearly you'd rather not put anything in. But it's not like putting something into the lungs where you affect the cough reflex, you get colonization. So I think that we often have tubes in the stomach, in the esophagus for feeding. So my guess is it'll be similar to that. I don't think it'll be a huge problem. I don't think feeding tubes in general are a huge problem. So that would be my take on this.
but I think also the neonates have it's a very routine care.
Yeah, and in the neonates, they're first of all, if you can get the tube to stay down for 5 days, because these babies pull them out all the time, but they leave them in for 7 days, these feeding tubes. And it's exactly the same feeding tube. All we've done is we've mounted the sensors on it, and these are antibacterial, medical grade sensors. So, the rule at my hospital is 7 days. I don't know about the adult ICU. I think it's 7 days. And when we do our studies, we've told Health Canada, and they've approved the 7 days staying in.
But it's also like in terms of like best treatment. I mean, today you would keep the patient probably at an angle so you'd avoid aspiration issues, but even to have a feeding tube in would relieve your abdomen so you would actually reduce the risk of aspiration. For non-invasive, I mean, the thing is that you are removing the endotracheal tube, and I think for many situations, if you have severe exacerbation of COPD, if we take that as a classical example that I see, and you see that you have to deliver so much PEEP that you must intubate to keep the PEEP level up. Now you can just put a mask on this person, put a nasogastric tube, and the only thing you do is that you're just triggering at the right time, delivering the amount of assist that you need to overcome the trigger threshold, and you ventilate him. And he doesn't need PEEP for any other reason than to just trigger. There's no need for PEEP. It's not, if you take acute lung injury non-invasive, you have to keep the lungs open. And in this case, you might not be able to provide enough assist. But I think that the thing here is that the cost of putting a catheter in the esophagus compared to intubate a patient, I think that the risks of infection going through the trachea is we know it's worse. It is, I mean, to go intubate is dangerous. I mean, it's just like that.
And you don't have to use the 16 French if you're going to do non-invasive in an adult, because if they're eating themselves, then you can actually put a very, very thin catheter down, not used for feeding. You could use the baby catheters if you wanted to. So you could go very, very small as well if you're not going to use it for feeding.
Your point's a good one, however, for quote non-invasive ventilation, you have to put something in the esophagus when normally you wouldn't have to. Have to see whether the risk-benefit pays off. The risk is not great, but you have to look at the risk-benefit in clinical studies. Any other questions, comments? Two questions, one in the second row, here in the corner, second row. And then the front row here. Yeah.
I think we've focused a lot on triggering, but as a neonatologist, the elimination of active exhalation is probably more important in reduction of intraventricular hemorrhage, retinopathy of prematurity, and pneumothoraces. So I think from our standpoint, that would be far more important than the actual triggering.
We're starting a study. We're actually approaching the families. We're starting right now, where we're going to compare conventional triggering on to neural triggering on, and we're going to compare neural cycling off to conventional cycling off in pressure support mode. So we're going to look at these in the less than 1 kilo babies, and we'll be able to see if the synchrony can be improved.
The second question is, there's old work by Charlie Bryan and Yusuf, who basically said that that the beginning of active inspiration is before the end of passive exhalation. And that's the way we maintain our FRC. As far as in a newborn, I don't know about adults. And I wonder if you have a drop in compliance, whether that's when you see the baseline increase in electrical activity, as opposed to in a normal baby, you probably wouldn't see it at all.
We haven't actually measured compliance in these babies. What I can tell you is that the ones that had the highest tonic activity were the ones who were the smallest in gestational age, who were the sickest. They were the longest on mechanical ventilation and had received multiple doses of surfactant at birth. But I did not measure the compliance at the time we did the study. We know from our rabbit data that a healthy rabbit doesn't have very much tonic activity. There's very little. But when you do the lung injury and the compliance is reduced by half, then you see the presence of this tonic diaphragm activity.
Is there a inverse relationship between the electrical activity of the from the diaphragm compared to the cricopharyngeus as far as maintaining FRC?
Compared to which muscle?
The upper airway muscles?
We did a study, and when we did a CT study and looking at the recruitment of the lung, and we actually started to measure the upper airway activity. We haven't analyzed the data fully, so I cannot say, but the impression we got when we were looking at it is that you have more or less an inverse activity, so that the upper airways are kind of relaxing when you're breathing in, and you see them contracting when you are actually letting go. So there is like a PEEP effect of the upper airways. This is in non-invasive situation. Then, of course, when they're intubated, they have it too, but it doesn't work. So and we could see that if they were non-invasively ventilated, they could keep the lungs open totally much easier than if we had them not. If we intubate them, it's like to just ruin one very, very unique thing we have, because even we would, would be able to keep. You have like pursed lip breathing, for example, in some patients. That's another of those things that is, you see it in very sick patients, and this could be that they have problems to keep lungs recruited sometimes.
This upper airway mechanism probably explains why you don't get gastric distension in patients or animals on non-invasive.
Yeah, I mean, the very concept of not applying PEEP with this method. I mean, it's so weird. That strikes me that I'm sure that if people are starting to use this system, I mean, everybody tends to go and, you know, gotta have some PEEP there. I mean, could you? And I would worry about collapsing of lung based on, you know, of years of hammering in my head, you know, enough PEEP. So would you comment on that? Would you not have some measure of either collapsing or not collapsing of the lung in clinical setting, that is?
Well, I think I mean, for the adult patients, I think with today's practice, I mean, I don't think you should change anything as a starter. The version we work with in adult patients, we have a set PEEP. We don't deliver any proportionality during the exhalation period. And we stay with PEEP according to today's practice. We assume and we have shown that the upper limits of tidal volumes is in the protective range, so that you don't over-distend your lung. But we think that one step at a time is a better approach than to just let everything go at once, because it's so difficult. And I mean, this is one thing I would like to ask you guys in a sense. It's like, I mean, it's always coming back to us. I mean, this sounds very good. We show it, it's beautiful, and it does really work very well. But in practice, in clinic, I mean, when you work, I mean, this is very far away from where you guys are today, what you're doing. I mean, you're still going to start to work with feeding tubes, connectors to the patient from the feeding tube, and look at diaphragm activity, talk about hearing Breuer reflexes, etc. So how do you foresee this? I mean, how do you see this happen? I mean, it's like...
Well, we talk every day about hearing Breuer.
Yeah, well, that's good. But I think it's I think this is like really the important thing here is to create like a bit of a teamwork here where because I feel sorry for PAV, for example. I don't think it's so bad as a mode that it kind of ended up as. It's in the same league. It's maybe not as efficient as NAVA, but it definitely deserves as well something. There are other modes we discussed, BiPAP or APRV today, for example. And it's easy to say, I tried it, you know, it didn't work, it was really whatever. And, you know, I mean, I've been doing this for 30 years, so this is like easy. So the thing is here to see how we can get about, because, I mean, there is a inertia to get everything going. And with this mode, it's going to be a lot of good things for you that I'm sure of. But it's also a lot of change of practice, and who is going to take those decisions and say, okay, now we're going to change our practice. This is...
You mentioned, you talk about hearing Breuer every day. I'm sure it's true if you're from Scandinavia, and at least talk about herring every day. I mean, I don't know about the Breuer part. Any final questions, comments? Good, let's first thank CRISPR and Jennifer.